Hello, and welcome to Team PH's Current Research and Evolving and Therapies webinar. I'm Leslie Orlovsky, the Executive Director of Team Phenomenal Hope, and we are excited to have you with us for the first of our PH Awareness Month webinars. This year, instead of having all of our educational webinars during the month of November, we've decided to spread them out for viewing purposes to make it a little bit easier for you to join us. And before we get started, I just wanted to share with all of those joining us tonight, Team PH prides itself on helping our patients. We encourage those that are listening to share our programs throughout the PH community. We are here for you. I am so grateful to our supporters for allowing us to continue and increase the Megan Michelle Hicks Fund for Unmet Needs, which allows us to put real dollars into the hands of our patients to meet just some of their unmet needs. We couldn't do this without your support. Please visit teamph.org for more information. With that, I am pleased to introduce you to tonight's presenters. Please join me in welcoming Dr. James Ford of UNC Pulmonary Clinics, Dr. Megan Cirillis of the Intermountain Medical Center, Dr. Todd Kolb of Johns Hopkins University, and Elise Whalen of Texas Children's Hospital. I will hand it off to Dr. Ford to get us started with PAH clinical trial basics. But before, just some housekeeping. If you do have questions, please put them in the chat and we'll get to them at the end of the presentations. Dr. Ford, I hand it off to you.
Thank you. Everyone, it's a pleasure to be here. Thank you for the opportunity to talk to you about pulmonary hypertension and evolving therapies and ways that we can assess and better treat the disease. So my role is to start off and give you a bit of an overview of where we stand in terms of the development of therapies for pulmonary hypertension and where we might be going in the future. So to start off with, I think it's important to focus on what is the fundamental problem that we're trying to address here. And as you may be aware, pulmonary hypertension simply represents an increase in the pressure in the pulmonary blood vessels, which are noted on this diagram here in blue. And when the pressure increases in these vessels, it ultimately puts strain on the right side of the heart. So what we're ultimately trying to prevent is right-sided heart dysfunction and failure. And pulmonary hypertension can be caused by a number of different mechanisms, and that's why we divide it up into 5 different groups, 4 of which we'll focus on this evening with respect to therapy development. In simplest terms, group 1 pulmonary hypertension really results from an abnormality within the small pulmonary vessels, of which there are tens of thousands throughout the lung. And this is the type of pulmonary hypertension, or PAH, for which our current therapeutics have been developed and continue to be developed. Group 2 and 3 pulmonary hypertension are the result of left-sided heart disease and intrinsic lung disease, respectively. We've begun to investigate therapeutics for these type of pulmonary hypertension as well, and we'll hear more about that as we move forward in this presentation. Group 4 pulmonary hypertension is caused by chronic pulmonary embolism or chronic thromboembolic disease. And we do have therapeutics for that, not only medical, but also surgical and interventional catheter-based treatments. Group 5 pulmonary hypertension is the most complex and poorly understood, and we don't really have a lot of good therapeutics for that. We could spend many hours talking about all the different types of pulmonary hypertension, but we don't have time for that tonight. But just so we have a basic overview of the fundamental central problem of increased pulmonary pressure leading to right-sided heart dysfunction, which we're trying to prevent. So there's been a lot of progress in pulmonary hypertension drug development, particularly over the last 3 decades, and even in many decades prior to that, in understanding the potential mechanisms of disease and what drugs we might begin to target to study. We've had a number of new therapeutics developed over the last 3 decades and promise for even more, which we'll hear about. But it's important that we continue to strive to develop treatments to improve the survival and physical functioning of patients, because though we have made significant strides in patients' physical functioning, symptoms, and survival, the survival rates, particularly in the intermediate and longer term, remain unacceptably low. So our goals really are to halt disease progression. If we can, reverse the abnormal remodeling of the pulmonary blood vessels that occurs in the disease, and ultimately, hopefully, find a cure. No matter what we do in terms of drug development, past, present, or future, it will all remain insufficiently realized if we don't continue to increase awareness and detect the disease earlier to really maximize the effectiveness of our current and future therapeutics. So the development of the new PAH therapies is really the same as applies to most disease processes. A theoretical basis for possible efficacy is established through research, particularly basic science, laboratory-based research of biological pathways and how they may or may not be implicated in the development of pulmonary arterial hypertension. This research is supported by private and public grant funding that helps us discover new potential pathways and identify compounds and molecules that we can study that might be effective in treating the disease. And once through substantial research, enough plausibility has been determined that a treatment may work, then clinical research in humans is carried out in a stepwise process. And this is shown here on this slide, which takes you through the phases of drug development and clinical trials. And this applies to not only to pulmonary hypertension, but all drug development in all diseases. So we start out with, as I mentioned, preclinical laboratory studies. And in the world of pulmonary hypertension, this largely centers around animal models of pulmonary hypertension and testing compounds, evaluating what they do to pulmonary pressures and pulmonary vessels in these animal models. And once enough evidence is present to suggest that they may be effective in humans, we can move on to human research studies. A phase 1 clinical trial is focused largely on safety and doesn't even necessarily involve patients with the disease, but rather seeks to understand what happens in humans who are often healthy subjects of this phase who are exposed to a drug. Is it safe? Are there toxic effects that really would keep it from being developed any further? And this usually involves a few dozen participants. Once the drug successfully moves through that phase without any significant concerning safety signals, then phase 2 study ensues. And this continues to focus largely on safety, but also begins to explore dosing, what kind of doses can be tolerated, and also what may be effective. So some effectiveness or efficacy endpoints are looked at as well. And if promise continues to be seen at this phase, which usually involves in the world of pulmonary hypertension, about 50 to 200 participants, could be more, could be less. And these numbers can vary widely depending on which disease one is being studied. But I've tried to put some numbers that really fit pulmonary hypertension clinical studies. We can move on to phase 3, which is really the phase upon which approval of drugs are based by regulatory agencies, which in the United States is the FDA. And this focuses largely on efficacy with also continued assessment of safety, and sometimes can explore varying doses as well compared to a placebo. Once a drug is then proven to be effective and safe and a dose is established, it is then hopefully FDA approved and then brought to market for treatment of patients. Additional phase of study called phase 4 may continue to progress, which may be sometimes mandated by regulatory authorities looking at continued aspects of safety or efficacy or potentially different doses. Phase 4 studies can also be initiated by investigators or sponsors to answer new questions about how a drug may work potentially in different types of pulmonary hypertension or different populations. And that can have a variable number of participants. So we've come a long way in pulmonary hypertension, not only in developing therapies, but in understanding what new potential pathways may need to be targeted. And I think this, just to give you some idea, the The figure on the left here was from a New England Journal of Medicine article published in 2004, which shows the three main pathways, which are still the only three pathways for which our current therapeutics are targeting. Even though we have so many, they still target these three fundamental pathways. But if you look here on the right, from a review on pulmonary hypertension drug development published this year, very recently, you can see there's a whole host of different potential pathways. And not only have we gained an understanding that they may be targets, but we've even identified compounds that may be effective and are primed for clinical study in humans. So not only have we developed new therapies and new understandings of the disease, but we've also changed out of necessity the way we do pulmonary hypertension trials. You can see this figure here, which shows most of the pivotal trials, starting with bosentan all the way down to oral treprostinil. And you can see that these trials were relatively shorter, on the order of 16 to 24 weeks, and enrolled relatively less patients. And they were looking particularly at functional endpoints. How far can patients walk in 6 minutes? But as we continued to study the same pathways and new drugs treating the same pathways, and as more and more patients were on treatments, we had to change the way we did trials to show effectiveness. So our trials started to become longer and look at different types of endpoints, such as hospitalizations, mortality, the need to increase therapeutics, and things along those lines. And as we start to study new therapeutics, the pendulum may shift a little bit back towards our original way of doing things, where we are able to look at shorter duration trials, but that have a richer set of endpoints associated with them. So really, there's a lot of opportunity, but still a lot of challenge when it comes to developing drugs for pulmonary hypertension. One of the biggest challenges we face is that many patients have already been on therapy for long periods of time, since we now are approaching nearly 3 decades of approved therapies. So you can imagine the patients that we enroll in trials already being treated with drug, it's going to be harder to show effectiveness of a new compound on top of existing therapy. And similarly, there's a smaller pool of patients that have never been treated that are identifiable as potential clinical trial participants. But this also really emphasizes the need for new drugs that work in new ways to provide added benefit. One of these, which is a prime example, is sotatercept, which you'll hear a lot more about soon. So it's important to keep in mind that participating in a clinical trial, it is a big commitment, but it also provides a huge service, not only potentially to the patient participating, but to the larger PAH community in terms of researchers and other patients. So what we'd really encourage, as you hear about all of this drug development, if you're interested in participating in clinical trials, one of the best resources for that is a US government website called clinicaltrials.gov, where all of research in pulmonary hypertension therapeutics is all stored there and searchable either by disease. You can type pulmonary hypertension or PAH. By location, it tells which investigators are participating, what sites. You can search by a particular drug name. It's a really user-friendly interface to help identify areas where patients can participate in clinical trials. So with that, I will turn it over to Dr. Saroulis, who will tackle Group 1 pulmonary hypertension and potential therapeutics in that area.
Well, thank you so much for the opportunity to be here and the wonderful introduction from Dr. Ford, going through a lot of things that we'll talk about in this talk as well. So as Leslie mentioned in the introduction, I'm from Intermountain Medical Center in Murray, Utah. So on the other side of the world, it feels like sometimes. All right, so I'm going to be talking about Group 1 PH updates, and we wanted to talk about some changes in diagnosis, talk a little bit about risk stratification, and then also treatment. So I think it's really important to first highlight that the actual definition of pulmonary hypertension has changed, and this changed in 2022 when the European guidelines were published. And As was mentioned by Dr. Ford, pulmonary hypertension is really defined as a pressure above a certain threshold, which we call abnormal. And we talk about precapillary, postcapillary, and combined pre and postcapillary pulmonary hypertension, depending on where the pressure is sort of seen to be abnormal on the heart catheterization. In group 1 PAH, which is the topic that we're focusing on in this section, is a precapillary pulmonary hypertension. And so this is relevant in that when the guidelines changed, we went from the threshold being 20 millimeters of mercury, or 25, excuse me, down to a pressure of 20 being considered abnormal and making the diagnosis of pulmonary hypertension. And then also recently, there's been a change in the pulmonary vascular resistance definition, which many patients will be aware of what their initial PVR numbers were. And that went from 3 to 2 on the Wood units. And so I think it's just important to highlight that it's really not clear at this point how this is going to change clinical practice. And I think a lot of clinicians are still struggling with sort of how to integrate this into clinical practice. And also, most research trials are starting to include these updated definitions, but I think it will be some time before we see a complete shift. The next major change I wanted to discuss that has been something that's been changing over years, not abruptly, but really this focus on risk status instead of just pressure. So we use the pressure numbers to define pulmonary hypertension, and sometimes we'll say mild, moderate, severe pulmonary hypertension based on the pressures that we get on the heart cath. But that's really not what we're focusing on most recently in terms of how we decide to treat patients. So a number of risk scores have been developed throughout the world that use different characteristics to predict survival in group 1 pulmonary arterial hypertension. And you can see here in this table, there's a big list of things that we'll put into a calculator depending on which risk score you're using. And those kind of spit out a prediction of 1-year mortality in some cases, and et cetera. And these are European. The REVEAL has been mostly in a US population, and then there's also a French score. And so typically they'll be categorized as low, intermediate, and high risk based on these characteristics. And why that matters is that both for 2 reasons, really. It helps us guide how we talk about survival in sort of the more modern era at the time of diagnosis. It also helps us define how we're going to treat patients. And so I think patients, you all may hear your providers talk about your risk status, and that may drive how they're initially deciding to treat you. So as you can see here, vasoreactive patients are kind of in a different category, but in the non-vasoreactive patients, we really look at low risk, intermediate risk, and high risk, and that helps to determine what initial treatment strategy is approached, whether that's just 2 oral medications, or if patients are in a higher risk category, that may mean that we use triple therapy up front with an intravenous or subcutaneous prostacyclin medication. So as I mentioned, risk status really drives treatment and will continue to play a part in initial and follow-up treatment decisions as we move forward and further refine these risk scores to be more useful. It also, I think, helps to explain why either your providers and care teams do what we do at follow-up visits. So sometimes it feels silly to be getting blood work again or doing another 6-minute walk, but it's really important for us to be able to help understand how things may be changing in terms of risk based on after treatment has been initiated. I think in the future, we'll probably start to see risk scores used as outcomes in clinical trials, but there's a lot of issues with that come up, and they're certainly not perfect and ready for prime time at this point in the game. So, but I think that may become more common. And then you may also hear your provider, your care team talk about your risk being whether it's low, intermediate, or high. So I think it's just important to highlight what that means. Okay, and then sort of the last update before we dive into treatment is talking about outcomes and assessments. So Dr. Ford mentioned, that the clinical trial outcomes have changed over time from looking at 6-minute walk alone to things that are more combined endpoints, sort of looking at bigger picture outcomes. And I think there's also been a shift in interest toward more real world assessments. So as all of you probably know, we all have good days and bad days. And some days your 6-minute walk distance really may not reflect how you're actually doing in the big picture. But in the past, that has been a really key outcome in a lot of clinical trials and is often done in clinical practice, is included in the risk scores, et cetera. So there's been increasing interest in using more real world assessments such as step counts or sort of movement during the day that can be measured with smart devices like watches, et cetera. So there was actually a recent study looking at step counts and showing that patients that have higher step counts are less likely to be hospitalized. And so perhaps we can be integrating these types of outcome measures into our day-to-day practice and watching patients sort of from the clinic perspective and helping to identify when folks are getting in trouble or if we need to escalate therapy. Okay, so stepping into the treatment arena for Group 1 PAH, wanted to start first with really where we've been. And again, Dr. Ford highlighted this nicely. So we've really been focused on three pathways that are all aimed at essentially increasing dilation of the blood vessels in the pulmonary circulation and reducing cell proliferation or cell growth. And we've targeted that with these 3 pathways: the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. And you'll probably all see drug names here that you recognize or may have had exposure to. And so really it's just been different ways of targeting these pathways. And that has been very successful and I think changed a lot of lives and outcomes in terms of PAH. But as mentioned, I think we have a long way to go. So this is really where we're headed. This is a similar figure to what was shown previously, just in a slightly different way. But all of the red boxes are potential drugs that are out there in development, looking at these different pathways that we may be able to target to modify pulmonary arterial hypertension. And really zooming in on there's too much to talk about if we want to talk about all those individual drugs, but focusing in on the blue boxes, I think it shows where we're headed in terms of targets. So really trying to target the abnormal growth of blood vessels, which is this dysregulated angiogenesis, still trying to target vasoconstriction and vasodilation, as we talked about previously, as well as cell death and cell growth. But there's also this increased focus on inflammatory pathways that are probably playing a role, oxidative damage, so reactive oxygen species, et cetera, and then changes in metabolism as well. So looking at drugs like metformin or other agents that may be able to modify the pulmonary hypertension disease process. So when you look at that table or that figure, I get very excited, but it's also really overwhelming. And I think can be hard to figure out how to navigate kind of what's coming down the pipeline or what we should be focusing on. So I just wanted to pick out and highlight a few things. First, really kind of looking at new drugs or doses in old pathways. So we think that we know the best way to administer drugs or the best dose, but there are thoughts out there that there may be other ways to improve upon things that we are already using. And some of you may be either enrolled in these trials or have heard of some of these trials. So the Unisys trial is looking at a higher dose of macitentan or Opsumit in PAH. There's a trial that is looking at an inhaled form of a drug similar to riociguat in PAH. We've got another trial looking at a different formulation of a drug that acts in the prostacyclin pathway called ralinepag. That's similar to selexipag, but dosed once daily, and there's thought that it may be more potent. And then there's also been interest in looking at a different formulation of treprostinil that has a longer half-life, so would have less frequent dosing. And so I think the goal for the most part is making some of these drugs more easy to take for patients. So reducing the number of times you have to take it during the day, or hopefully having them be more efficacious. There's been a lot of excitement about sotatercept, and we already sort of touched on that in this talk. So I just wanted to, there was actually a discussion about it last year during this webinar, but wanted to circle back and see where we're at. So as a review, sotatercept is a kind of totally new pathway that we're targeting for PAH in this BMPR2 and TGF-beta pathway, with the idea that it will rebalance some of the cell proliferation or cell growth that gets dysregulated in PAH. We had really promising results in 2 studies. So PULSAR, which was a phase 2 study where the drug was able to lower pulmonary vascular resistance. And then the STELLAR trial, which was a phase 3 study and showed an improvement in 6-minute walk distance. There are still 2 trials ongoing, and some of you on the call may be participating in those trials. So thank you if you are. That's HYPERION, which is looking at newly diagnosed patients, so who are within 6 months of their PH diagnosis. And that's really trying to get at, I think, what Dr. Ford was mentioning, and that a lot of patients are coming to these clinical trials already having been on therapy for a long time. And then there's also the ZENITH trial, which is looking at high-risk patients, so high functional class, meaning that having a lot of symptoms or with a high REVEAL score, which portends sort of worse survival. So I think everyone in the clinical realm is hopeful that this sotatercept will come to market after FDA approval sometime in 2024, but we don't have a firm timeline on that. And then I wanted to just talk about one other kind of class or group of medications that there are active trials ongoing that I think we should all be looking out for. So this is the tyrosine kinase inhibitor and similar agents. So like I said, there are 2 trials going on with drugs that are somewhat related, but kind of slightly different. And the real goal of these medications is, again, to target irregular vessel growth, fibrosis, and inflammation. One drug is called imatinib. There were fairly promising phase 2 and phase 3 results, but a high rate of serious adverse events or side effects from the medications. So the studies were stopped. But they're trying to look now at that imatinib drug in a different form, so inhaled instead of taken in a different way. And there's an ongoing phase 2b/3 study looking at that medication. And then a similar drug called, similarly hard to say anyway, seralutinib. So there was a study called TORREY, which was a phase 2 trial looking at inhaled seralutinib, which met its endpoint of reducing the resistance in the pulmonary circulation. And the main side effect there was cough, which seems fairly common with our inhaled PH therapies. And then there's a trial that will hopefully start soon, which is PROSERA. And this is going to be looking at a combined endpoint of time to clinical worsening, which often includes things like hospitalization or worsening of risk class. And so I think these are this study is an opportunity for patients to potentially get involved with one of these trials. So just summarizing kind of the key things that we've talked about today. So the pressure and resistance definitions of pulmonary hypertension have changed, which may change how we diagnose it and how trial inclusion and exclusion are designed in the future. Treatment strategies are really focused a lot on risk status at this point, which incorporate not just how severe the pressure is, but lots of different characteristics about the patient and the disease. And then I think the future is really bright for PH therapies. We have a lot of incredibly smart people working on these complex pathways, trying to both improve current treatments and also design new agents down in the pipeline. And these are the references. Clinicaltrials.gov is a great resource to make sure you're staying on top of what's available. And then there are a couple of recent reviews that are useful talking about these therapeutics. that's what I have, and I will pass it over to our next presenter.
Okay, great. Thanks, Megan. It is a pleasure to be with you all tonight. My name's Todd Kolb. I'm a PH doctor at Johns Hopkins in Baltimore. Been tasked with covering a lot of ground in a short amount of time here. So let's just go ahead and get right into it. So I'll talk a little bit over the next 15 minutes about pH associated with other medical problems. So the three groups that I'll mention are pH associated with left heart disease or group 2 pH, pH associated with chronic lung disease or group 3 pH, and pH that's associated with pulmonary artery obstruction, most commonly CTEPH, and that's our group 4 disease. And this is really a very broad range of diagnoses. They range from very common problems to very rare problems. And with the exception of CTEPH, there really have been very limited treatment options other than managing the underlying disease itself. And so historically, a talk like this would actually be very brief, maybe 2 or 3 minutes, but I'm happy to report we have a few exciting updates to talk about tonight. So we'll start with group 2 pH. And again, that's pH associated with left heart disease. That incorporates lots of different diagnoses. It includes pulmonary hypertension that arises as a complication of problems in the heart valves on the left side of the heart, the mitral or aortic valves, as well as pulmonary hypertension that arises as a complication of congestive heart failure. And in the interest of time, I'll try to focus some attention on some updates and novel therapies in the treatment of one particular form of congestive heart failure called HFpEF, or heart failure with preserved ejection fraction. I'll touch on the limited data on pH-specific therapies and then just mention one quick thing in the pipeline. So I think the real progress here in the last couple of years has been in targeted therapy specifically for HFpEF itself. So I'll just say that these treatments are not clearly shown to improve pulmonary hypertension in left heart disease or HFpEF, but they really have expanded the arsenal for drugs that we have for patients with this problem of HFpEF. And HFpEF is a very common form of heart failure where the heart is pumping normally, but it's too stiff to fill properly. So fluid builds up in the blood vessels of the lungs and ultimately leads to pulmonary hypertension. And I mentioned it's common. There's probably 3 million people in the US alone with HFpEF, and somewhere between 50 and 80% of those patients might have pulmonary hypertension, and the symptoms can really be disabling, very severe shortness of breath. Up until the last couple of years, the therapeutic options have been very limited. They focus on using diuretics for patients that are fluid overloaded, and then managing many of the underlying problems like high blood pressure, diabetes, cholesterol, getting regular exercise, losing weight. Within the last couple of years, there have been 3 different classes of medication that have been approved by the FDA to treat HFpEF. Maybe the most exciting in all of those in the last couple of years has been a group of drugs that was developed for treatment of diabetes called SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors. And I really can't pronounce these names. They're commonly known as medicines like Jardiance or Farxiga. And in large clinical trials with lots and lots of patients with all different types of heart failure, including heart failure with preserved ejection fraction, these drugs have really been helpful in improving cardiovascular outcomes in these patients. In HFpEF specifically, the benefit really seems to be in reducing heart failure hospitalizations. And I think importantly with this group of medications, one of the drugs, Jardiance, was shown in a small trial of patients that also had a monitor implanted that could continuously measure the blood pressure in their lungs, demonstrated that over the course of about 3 months or so, the blood pressure in the pulmonary artery actually decreased in patients on this particular medication. So I think that's a hopeful sign for potentially for patients with left heart disease associated pulmonary hypertension. Other classes of medicines that have recently been approved by the FDA for use in HFpEF include medicines like spironolactone, which some of you may already be on, and another class of medicines called angiotensin receptor neprilysin inhibitors. And the branded name for this that you may have seen on television is Entresto. And although we don't know whether these medications have specific benefit in pulmonary hypertension as a consequence of HFpEF, they definitely have been beneficial in the underlying problem itself and have expanded our arsenal there. Very recently, and I think very exciting, is that, again, this is specifically in HFpEF, not pulmonary hypertension from HFpEF, but there's, within the last month, there's been a large randomized trial published in the New England Journal that shows a medicine called semaglutide. Again, you probably know it or have heard of it by its more popular name, Ozempic, has some really promising effects in patients with HFpEF. So this class of medications, they're called glucagon-like peptide receptor 1 agonists, are FDA approved already for weight loss. That's why they get most of their popular attention. And these drugs were tested in a phase 3 clinical trial comparing in patients with HFpEF and obesity, so BMI greater than 30. And importantly, over the course of 52 weeks, the study showed that there were really substantial improvements in patient-reported heart failure symptoms, physical function, quality of life. There was a substantial increase in weight loss in the patients that received semaglutide, about 11% of body weight. And importantly, their 6-minute walk distance improved by about 20 meters as well. There really were not many adverse events, and patients tended to stay on the medication throughout the course of their therapy. So another potential tool in the arsenal here, not yet translated out to pulmonary hypertension, but I think having drugs to treat the underlying problem is really something that's exciting in this field. So in terms of specific therapies for PH left heart disease, and maybe more specifically PH-specific therapies, there really are none that are approved. And that is because over many years and many trials, lots of the medications that we use for PAH have been shown to be either unsuccessful or harmful in improving symptoms or other outcomes in pulmonary hypertension with left heart disease. I will mention sotatercept, which Megan just talked about. There's a lot of excitement potentially about sotatercept in PH with left heart disease as well, largely because the mechanism of action really is to kind of restore this balance of proliferation in the pulmonary circulation. And the thought is that that particular approach might be helpful in this particular process. So there's currently a phase 2 study targeting about 150 subjects with HFpEF and pulmonary hypertension that'll get sotatercept or placebo for about 6 months. And so that, the field is potentially expanding here. Hopefully won't end up in the same pathway as our previous PH trials. Okay, pipeline, lots of things in lots of pipelines. I chose to kind of stick to things that are closer, maybe the phase 3 trials that Jimmy had mentioned. I'm going to skip over the medications just for the interest of time, but kind of one interesting idea that's currently in phase 3 trial is this concept of pulmonary artery denervation. So this isn't a medication, this is an actual procedure, catheter-based procedure, where during a right heart catheterization, a catheter is inserted into the pulmonary artery. That catheter is able to deliver high energy sound waves or ultrasound directly to the nerves that cause the pulmonary artery to constrict. And the hope is that will ultimately reduce the blood pressure in the pulmonary artery and help with symptoms of pulmonary hypertension. In a small phase 2 trial of about 100 patients with left heart disease, pulmonary hypertension, there were really impressive improvements in exercise capacity or 6-minute walking distance, as well as some of the measurements on right heart catheterization. And because of that, those outcomes, the treatment is now in a phase 3 trial that is intended to enroll patients over the next couple of years. Okay, sorry, because of the scope here, there'll have to be some high-level discussions on some of these things. We'll move to group 3. This is PH associated with chronic lung disease. Generally, we're talking about patients that either have various forms of interstitial lung disease, where the normal lung tissue is replaced by scarring and fibrosis, or obstructive lung diseases like COPD that may be related to smoking or other exposures to the lungs and might lead to tissue destruction. The biggest advance here in the last couple of years is the approval of inhaled treprostinil for ILD-PH. So we'll mention that a little bit, and then I'll also touch on its effects in COPD-PH. Megan already mentioned some of the changes in treprostinil formulation. I'll touch on that again, and then I'll also mention some things in the pipeline. So this was really revolutionary in kind of all of these different disorders. Inhaled treprostinil or Tyvaso being approved for interstitial lung disease was really the first pH-specific therapy in either group 2 or group 3 disease. And that approval was based on the results of the 2021 INCREASE study that looked at effects of inhaled treprostinil on patients with different types of interstitial lung disease-associated PH, including a very difficult form to treat called combined pulmonary fibrosis and emphysema. And the study showed really substantial benefits in exercise capacity or 6-minute walk distance, reductions in NT-proBNP over the course of about 4 months. And then, as Jimmy alluded to, over a longer period of time, improvements in the frequency of clinical worsening. So people tended to stay out of the hospital better. So because of the benefits of this study, the drug was approved for patients with ILD-PH and is regularly used. Some of you may be on this medication now. Unfortunately, in a parallel study of patients with PH as a complication of COPD, really not the same types of benefits were observed. And although we don't know much about what happened with this trial, it was stopped in September of 2022 after the initial regularly scheduled safety and efficacy review. So not on the horizon for an FDA approval anytime soon. A lot of attention over the last year or two has focused on changes in the formulation of inhaled treprostinil. Historically, we've delivered this drug as a nebulized liquid that has its own delivery system. That system weighs about 1 pound. It takes 2 or 3 minutes to deliver the medication. The equipment needs to be cleaned every day, and it can be a little bit cumbersome. So more recently, a smaller, more portable dry powder formulation of the medication can be delivered through a smaller, more portable inhaled system. And this dry powdered inhaler formula, or DPI, was approved by the FDA in 2022 after a small trial in patients with PAH that showed over the course of the first 3 weeks of switching from the nebulized form to the dry powdered inhaler form, there was no worsening of 6-minute walk distance. And in fact, when this small group of subjects were followed out over a year, their 6-minute walk distance actually continued to improve, probably because of titration in the drug. Maybe most importantly, though, the scores for patient preference are really off the chart. Patients tended to love this formulation and because of its convenience. And so there's been a lot of interest in this potential mechanism. As Megan mentioned, there is a longer acting form that's in development now. This is actually a prodrug of treprostinil. The body converts it into the active drug. It may last up to 24 hours in animal models, and it is currently in phase 2 testing for patients with PAH. So not right around the corner, but maybe on the not too distant horizon. In the pipeline here, there are a couple of options that maybe focus on that nitric oxide pathway that's been mentioned. One is the drug that Megan just mentioned previously for PAH, a kind of an inhaled once-a-day formulation of riociguat. That is currently being tested in a small phase 1 trial for patients with COPD-PH, which has completed enrollment. And as Megan mentioned, there's a parallel study that's larger, phase 2, phase 3 study in PAH patients. So we should start to hear some outcomes for this particular medication, I think, in the next year or two. Maybe more directly, for many years, people have tried to think about ways that nitric oxide levels could be increased directly in the lungs by delivering nitric oxide to the lungs themselves. It's hard to deliver this medicine outside the hospital, but over the last 10 years or so, a smaller portable delivery system has been developed that is now in phase 3 clinical trials for patients with interstitial lung disease and PH. So potentially another important tool that we'll be able to add. And then last but not least, just to touch on a couple of things for group 4 PH, primarily CTEPH here, where the treatment of choice remains surgical for patients that have especially proximal disease. But it's increasingly recognized that there are patients that may not be surgical candidates, either because their disease is too far away, too distal, or they don't want surgery, or they have other medical problems that make surgery more dangerous. And for those patients, a couple of options have been developed over the last 5 to 10 years. A single medical therapy called riociguat has been approved and has been a mainstay of therapy. And then more recently, balloon pulmonary angioplasty, which is an invasive procedure and not a medication, has also been approved and is catching on. So the main update here has been physicians trying to think about how to use these two complementary therapies together in patients that are not candidates for surgery. And so I'll just summarize kind of 2 large studies that were published around the same time that compared directly benefits and risks of riociguat, the medical therapy, and balloon pulmonary angioplasty, the procedure. Both studies showed essentially the same thing, which was that over the course of 6 months to a year, balloon pulmonary angioplasty was probably a little bit more effective at lowering the pulmonary artery pressure or the pulmonary vascular resistance, but was also associated with more complications. And specifically, those complications were things like bleeding from the blood vessels of the lung or injury to the lung. What was really novel about the second study was that there was a group of patients who received the medical therapy with riociguat for about 6 months before they had the balloon pulmonary angioplasty. And the complication rate was much, much lower in these patients, about 14%, down from 40%. So it's making physicians start to think that, hey, maybe there's a way to harness both of these techniques together in patients that are not candidates for surgical intervention for CTEPH or have residual disease. So more to come about that, I think, over the next couple of years. And then finally, just what's in the pipeline for CTEPH. Kind of similarly to PAH, there is a active phase 3 trial looking at higher dose macitentan versus placebo. Again, this is for patients that are not surgical candidates or have persistent or recurrent disease after surgery. Expected completion next spring. And last, but I think definitely not least, for all patients with CTEPH, even those that are operative candidates, the question continues to linger what the best form of anticoagulation is. And we have historically used preferentially warfarin because of risks of recurrent clotting, primarily in patients with CTEPH. But there are newer medications that are much more convenient for patients, don't require monitoring, are more effective in other forms of acute pulmonary embolism. And so we really don't know the answer to this question because no one's asked it directly, which is warfarin more or less effective than one of these more convenient forms? A study that's directly asking that question is ongoing now in Japan. There's a phase 3 non-inferiority trial of a medicine called edoxaban versus warfarin. And the endpoints there include both measurements at right heart catheterization, worsening of the clinical CTEPH disease, as well as some complications like major bleeding. So with that, I will turn it over to Elise.
Great, thank you so much. My name is Elise Whelan. I am a nurse practitioner at Texas Children's Hospital. And my goal over the next several minutes is to really just paint a picture of what life may be like for a patient, a kid who has pulmonary hypertension. I also think just hearing all of the clinical trials and all of the great work in adult PH, how does this all play into kids? You know, what are we using for therapies for pediatric patients? And so my goal over the next several minutes is to kind of throw in some, what is specifically different about kids, obviously, besides their age. What are current therapies that we use? What are some of our challenges, advocacy efforts, and of course, some current research. So pediatric PH is not PH in little adults. That's kind of what you always hear when you think about pediatrics, but we do follow a similar definition as adults. You know, we still follow the same hemodynamic criteria, still follow the less than 20, like for the cath and all of that. But there are some key differences. And so these are kind of some of the key differences, and some of them are similar to what you may see in adult PH, but a lot of these kids have PH. Maybe they were born prematurely, or they have congenital heart disease, or, and we do a lot of genetic testing in pulmonary hypertension. Maybe they have a genetic mutation, and then we end up getting parental testing, and we've discovered PH in them. And so there's just a lot to discover in this group. A lot of developmental lung diseases that, are contributory, things like that. And so not one PH patient is like the other. And I think that's the same as adults. So current pediatric therapies, we use several of the same therapies that adult patients use. However, of our medicines, most of them are off-label use. We don't have the robust clinical trial data to back up our use in kids. And I think that's what there's a lot of hiccups that come into play with these meds, especially with insurance approvals, as you can imagine. And so we have to be creative. We have standing letters. We have all the things that we can use to try and get a lot of these medicines approved. And a lot of these suspensions, because as you can imagine, trying to get a 2-year-old or, an infant to take a tablet, that's not possible. A lot of these suspension medications, like sildenafil suspension, for instance, is even more expensive than the tablet. And so it just creates a lot of challenges in that front to even get approvals. And then in terms of tolerance, I feel like some of our therapies that we find really helpful in some patients, you'll talk to adult colleagues and they're like, oh no, in our adult patients, we don't like to use this medication. And so I always think it's interesting to hear kind of what adult physicians and adult teams are using, because our experience might be a little bit different in children. So highlighting some of the main central pediatric care challenges. So the Pulmonary Hypertension Association accredits, as you guys all know, PH centers, and there's a lot of adult centers, but in kids, there are only 9 that are comprehensive care centers, and the 9th one just got added this year. And so in Houston, where we live in Texas, our closest accredited center is in Nashville, Tennessee, which isn't close at all. And so we get patients from all over the country. We get patients from all over the world. And, just hearing about the clinical trials, some of the trials that they have in Europe, patients will come here on them for care, and they maybe I don't know. So they're on these funny meds in other parts of the country that we might not be doing in the US. And so it's really tricky. And trying to coordinate care. Like, we get a lot of patients from Dallas, which is about 5 hours away, just because there isn't just great pediatric PH care in certain parts of the state and parts of the country. And so that does create a little bit of a wrinkle. The other thing is an experience. So, pediatric PH is all about experience. How we're using these medications, what are the effects in children? How does the use of sildenafil, how does that play into somebody who has a developmental lung disease or a lung disease called bronchopulmonary dysplasia, which means when the babies are born so early, their lung development just kind of stops when they're born, and they take the time to grow from there. And so, the medications are used a lot of times based on experience in the dosing. And so that is a challenge. We'll have patients on tons of sildenafil, and they're on all these diuretics, and we're having to tier it back. And so that can be a challenge. The high cost burden, which I don't think is a pediatric care challenge that's specific to us, it's a PH issue in its own. But like I said, the suspension medications are quite pricey. The other thing that I get a lot of questions from parents are, well, my child is 12 and they're on Remodulin. What are things going to look like when they go off to college? What if, and I don't know how many parents are on this call, but I think those are real worries. How are they going to handle this when they're adults? And we have to work with families and work with patients and try to get these kids transitioned to an adult care center that can take care of them and help them with a lot of these issues. And so there are a lot of worries that I don't think adult patients may have, because they've already jumped that hurdle, right? And then the last thing is limited pharmacotherapy data, which I think I've already kind of touched upon. So advocacy for us in pediatrics is multiple layers. So we have to advocate for our patients in the school level. I have some patients where their teachers have never even heard of PH. Their communities, they're in, small small towns that, you know, they don't know what it is. And so let alone sending them home with a pump. We get a lot of, you know, we try to call the school nurses ahead of time, but we do have to advocate. There's bullying. There's, I had one patient who he couldn't tell his girlfriend he had PH because he didn't want her to know that he had a life-threatening illness. And so there's just a lot of psychological parts to that as well. And so we're always trying to advocate for awareness. And that's why I'm talking to you all today. Because I want the pediatric PH realm to also be recognized and understand that it doesn't just happen in adult patients. It can happen, you know, from in early infancy. I mean, premature infants. So I'm hoping to spread that awareness. Insurance delays, as of course, an insurance company is not going to want to approve a really expensive off-label medication. Care transitions. So as these therapies are used, a lot of patients are living longer, which is great. But now these patients are living into, you know, adulthood, and the transition from pediatrics to adulthood is a huge part of their journey. And so we partner a lot with adult centers to try and make sure that transition is smooth. And then the last one was, I think, the biggest one that's kind of rocked the pediatric world is the Remunity pump, which whenever we heard about it, we were just kind of told that that's what it's going to be. And I know myself, I alerted all of the other nine pediatric PH centers, and we were all on the phone trying to figure out how we could make this a better option for our patients, because the pump, the lowest dose that it can offer is not suitable for an infant, and it just wasn't created with a pediatric mindset. And so we had to advocate, and that's what we do, right? So several of our pediatric active studies, I'm not going to touch upon every single one, but we do have a lot that is out there. There is a sotatercept study that we're looking at in kids. The target enrollment is only 42, and we just started enrolling patients this year. But that is an exciting study for pediatric patients. And I know we're not a center for this clinical trial, but several of my patients have looked into Cincinnati Children's, I think, is recruiting patients. So it is exciting. And then, of course, we're looking at, starting patients up front on single versus dual therapy, all kinds of stuff to kind of learn more and try to build up our knowledge base of pediatric PH. Other things that we've been working on is actigraphy, the use of Fitbits, devices like that, because we can't do walk tests in an infant. They can't walk. We're trying to find ways that we can assess for exercise tolerance in these populations that just can't give us the information that we need. Other things like looking at Selexipag, Bosentan, just trying to kind of get more information. And I included studies that are in other countries, because I feel like as I've gone to conferences and I've talked to physicians and teams in other countries, their use of medications, their resources, they may not have as many of these medications available to them, and so they may jump to higher therapies than we may in the United States. So I think we're very lucky to have the resources that we have. That's all I have today. I'm hopeful that I was able to kind of give a little bit more perspective of some of the issues, some of the things that we're dealing with in pediatric PH. And I thank you for your time.
Thank you so much, Elise. I would like to open it up to questions. Before I say that, before I start reading the questions, in keeping with requirements, I just wanted to share that some of the drugs discussed this evening are not yet approved in the United States. And at this point, I just want to read, there was one that came into the chat earlier. To anyone on the panel, can you explain the difference between GP1 vaso versus non-vaso? What is this?
Vasoreactivity is essentially a small subgroup of patients with group 1 pulmonary arterial hypertension have really reactive blood vessels, and that when we test in the cath lab with certain medications, their pressures go down substantially. And why that matters is that, first of all, because the insurance companies often require it to get a lot of our drugs approved. However, that subgroup of patients seems to be different than the patients that don't necessarily have vasoreactivity in the cath lab. And we will often treat, at least up front, try treatments with calcium channel blockers, which are much more inexpensive medication to try, and they can be really effective in that subgroup of patients. So hopefully that answers the question. Happy to add to that if there's additional questions about it.
Not that I see, and thank you. I'd like to throw out the next question. If ILD is due to autoimmune disease, is a PAH patient only group 1 or 3 or both? Example, sotatercept will be approved for only group 1, correct?
That's a terrific question in the field. We have spent a lot of time grouping patients into certain classifications, and in fact presented all of these data based on those groups in each and every talk. But the reality is there's a lot of overlap among folks in the mechanisms that pulmonary hypertension develops. And there's a little bit of a disconnect between that reality and the way we study these medications in clinical trials, which is usually with a very narrow focus and a very specific group of patients, largely because we want to ask direct questions. And specifically the example of ILD and PH, historically, patients with autoimmune diseases like scleroderma were routinely excluded from trials of medications in ILD and pulmonary hypertension because there was a feeling that they would just do worse and they would potentially bring down the results of the study. It's one of the reasons why the INCREASE study was so helpful, I think, to the field, is because patients with connective tissue or autoimmune disease, including scleroderma and ILD, were included, and there was some benefit there. How it works in terms of approval still follows that old pathway, though. So as you probably saw, Megan talked about the sotatercept trials for PAH, and there have been many of them, and they're ongoing with lots of different flavors, and that's close to FDA approval. And then I mentioned a brief trial in kind of a tag-along trial in left heart disease PH, and that study will have to show some benefit for patients who have left heart disease PH to be approved for that particular medication. And that kind of dichotomy exists across all the different groups of pulmonary hypertension.
I just want to jump back to Megan because someone had a follow-up question. Would that vaso explanation cause severe edema with sildenafil?
Sometimes we have concerns that hypothetically, if a patient has a certain type of group 1 pulmonary hypertension called PVOD, there is a theoretical risk that if you give vasoreactivity sort of testing agents in the cath lab or treat patients with PVOD with vasodilators, that you could have edema in the lungs or water that kind of seeps out of the blood vessels in the lungs. I would not expect that vasoreactivity to cause edema peripherally. And so I'm not 100% sure, I guess, what the question is referring to. But yeah, we don't typically think of it being associated with peripheral edema associated with drug treatment.
Hey, thank you.
And I actually have a question for the other panelists about sotatercept. I was trying to look, but I don't know of a study looking at it in group 3, like as off another study. Is that true?
I'm not familiar with one.
Okay.
I didn't see that yet.
Yeah.
I'm sure it will come.
Yeah.
All right, we just have a few more questions if you have time. Are there therapies that are using the newer technology, CAR T cell therapy?
I'm not aware of any trials that are using CAR T therapy. If fellow panelists are, feel free to chime in, but I've not heard of any.
No, I have not seen CAR T therapy either.
I Googled it actually when that question popped up during somebody else's talk, and it looks like there's some interest out there, just given the sort of inflammatory cell pathways that are being looked at as well. So I'm sure somebody's thinking about it, but I don't think there's any mainstream trials at this point.
All right, thank you. Would you agree that it's critical to control inflammation in autoimmune disease affecting the lungs to prevent PAH in the future?
I'm happy to opine on that. I think in theory, yes. I don't think that we've proven that in a formal way through formal clinical trial investigation. But it does stand to reason, especially with all the emerging data about the role of inflammatory cells in the pulmonary circulation, that even particularly in the context of autoimmune disease-related pulmonary arterial hypertension, that a more specific focus on inflammation could be beneficial, perhaps not only in necessarily preventing the manifestation of pulmonary arterial hypertension, but also treating it once it manifests.
Thank you. And another question came through the chat. Can someone talk about the continuous PA pressure monitoring, and is it helpful?
To my knowledge, it's not used in the pH space specifically yet, but it is an implantable device that is used relatively frequently in the cardiology and heart failure space. So it's a small device that gets inserted into the pulmonary artery and continuously monitors the diastolic blood pressure of the pulmonary artery and can send that information to your physician, so that if that level rises above certain goals, it can allow the physician to adjust diuretics in real time. And there were some good studies that demonstrated benefit in heart failure patients in improving outcomes. It's not, to my knowledge, something that has been used in any trial for pulmonary hypertension.
Thank you. I think we've covered all of the questions for this evening. I don't think I've missed any. At this point, I wanted to share a huge special thank you to all of our esteemed speakers tonight for your time in sharing this important information with us. We are just so grateful. And I also want to thank our generous sponsors, Merck, Janssen, Arami Therapeutics, CVS, and Enzavant, for supporting us throughout our webinar series on pH awareness. I encourage each of you that are tuning in tonight to register for our other pH awareness webinars that are coming up in October and November. Our next one is on October 18th at 7 p.m. Entitled Inform pH Patients Tell All. And then in November, we'll have our research town hall. Once we conclude this evening, our rolling slides will have a QR code to register for those webinars. I wanted to thank you all for your time. I hope this has been helpful. Again, we are so grateful to our presenters. This has been such a learning experience for me. Thank you and have a good night.